Hello, everybody. I'm back. Dr. K.K. Agarwal, Heart Care Foundation of India and Confederation of Medical Association and of Asia and Oceania. You are watching Med Talks with Dr. K.K. Agarwal. This is 117th episode, non-stop and COVID-19. Let's have the headlines of the day. India needs 50 crore vaccines in the first phase, and India may get 100 million, that is 10 crore doses of AstraZeneca vaccine by December for a countrywide vaccination drive that could be launched in the same month. So 1 month from now, we may have 10 crore people getting vaccinated as per the government, healthcare providers, the front runners, the police, the people who are in the fire department, they have been put on priority. India continues to record less than 5 lakh active cases for 4 consecutive days. The recovery rate has now increased to more than 93%. The Delhi Chief Minister is hopeful that COVID-19 situation in Delhi would come under control in the next 10 days with the fall of pollution. On Friday, the United States reported a record number of more than 184,000 daily new cases. More than 65,000 people with COVID-19 has been hospitalized. According to a study published in Annals of Internal Medicine, patients who survive COVID-19 continue to have ongoing health problems. Around 40% of the people have these problems. Let's go to the subject of the day. Today is a World Diabetic Day, and on this occasion, I have a special guest. Let me introduce that guest. Professor Dr. Siddharth. He's a senior consultant in medicine and diabetology. He's a president Research Society for the Study of Diabetes in India, 2002 and 3. He's a president Scientific Session of Diabetic Association of India. He was the chairman Scientific Committee Association of Physicians of India. He's a patron of RSDDI Odisha chapter. He's a past chairman of API Odisha branch. He's a recipient of 20 National Oration Award, 160 guest update lectures delivered in more than 51 places. He received MRDF Lifetime Achievement Award. He received Lifetime Award of Diabetes India, Distinguished Service Award of RSDDI, and he is a member American Diabetic Association on special invitation, chairman Ethics Committee of Utkal University, Bhubaneswar, and much more. He's also a member Honorary Odisha High Court Legal Services Committee. So ladies and all my colleagues, I present to you Professor Dr. Siddharth Das on 14th November and on Diwali Day. Happy Diwali to everybody. Why 14th November is very important, Dr. Das?
Good evening, everybody. Happy Diwali to all of you. May I have the full screen, please? Slide slow, please. Yeah, it's a very, very unique day. It's a red letter day in the history of the world today, 14 November 2020, because it's Diwali day. So happy Diwali to all viewers, all those who have logged in, and all members of the Med Talk team. Today is also the birthday of Sir Frederick Banting, who discovered insulin way back in 1920. And that's why I wish to all persons involved for the betterment of the diabetics, people living with diabetes, and agencies caring for upliftment of diabetics. Today also is the birthday of late Pandit Jawaharlal Nehru, the first Prime Minister of India, which is known as Bal Divas, the Children's Day. So it's dedicated to all beloved children living with diabetes. So it's a 3-in-1. So it's a very unique day today. Next.
So when it comes to diabetes, there has been a recent research which says that if you have uncontrolled blood sugar today, whether you are diabetic in the past or not, rule out COVID-19. What is the relationship of COVID-19 and diabetes?
Well, COVID-19 can lead to hypermetabolic state and lead to simple stress hyperglycemia, which is acute hyperglycemia. And the most important thing is it can unmask latent diabetics, especially in pre-diabetics or the potent diabetics or IGTs. That is why the stress of COVID-19, if somebody is diagnosed to be diabetics during this pandemic of the COVID-19, it is wiser to exclude that he is a true diabetic, just not a hypermetabolic hyperglycemia. And diabetic state per se can alter many things. The morbidity status of the patient with diabetes, it can adversely affect the pneumonia, ARDS, winning from mechanical ventilation, length of stay in the ICU, as well as short and early mortality is high in patients with diabetes suffering from COVID-19. Glucose control and glycemic variability adversely is impacted by COVID-19. Centers for Disease Control, CDC, had mentioned that individuals with diabetes are at high risk of severe illness with coronavirus disease and poor health outcomes. So, research suggests underlying reasons for an increased risk of COVID-19 complications in individuals with diabetes may be due to poor glycemic control or uncontrolled hyperglycemia. So, the COVID itself can lead to stress hyperglycemia, and if a diabetic not properly controlled and gets infected with COVID, the situation is very worse for him or her. The incidence of infection is usually higher in patients with diabetes. Diabetics and hyperglycemia lead to neutrophilic dysfunction, poor chemotaxis of the neutrophils, defective macrophage mononuclear function. So the first line defense is definitely the innate defense of a type 2 diabetics or a diabetic per se is very poor. There's also deficiency of complement 4 and reduced cytokine response. Mononuclear cell and monocytes in diabetics secrete less of interleukins and would also reduce expression of class A MCH proteins. Decreased mobilization of chemotaxis and phagocytis activity may occur in with hyperglycemia and may increase the susceptibility to oxidative stress in diabetics. Glycation of the immunoglobulins harm the biological function of the antibodies. So the entire immune system is suppressed or is adversely affected with poor glycemic control, long-standing severe hyperglycemia. Well, COVID doesn't choose how to adversely affect which type of diabetics, irrespective of the type 1 diabetic or type 2 diabetic or a GDM or a secondary diabetic. So any type of diabetic can be adversely affected when infected with COVID-19. Type 1 diabetics and COVID-19, the preliminary findings from a multi-center surveillance study published in USA recently are shown. The study aimed to examine the patient characteristics and adverse outcomes among patients with type 1 diabetes with confirmed COVID-19. 64 persons with type 1 diabetes were confirmed. 50% of all reported hyperglycemia, uncontrolled hyperglycemia, and nearly one third of our patients landed up with diabetic acidosis or DKA. This is very important. If a type 1 diabetic gets infected, extra attention has to be given. This is our own report from a COVID hospital at Bhubaneswar. It's called as the Culling Institute of Medical Sciences COVID Hospital. It's first dedicated COVID hospital in the country. It started in March 2020. And if you look at the ward cases admitted in the COVID ward and those in the ICU, you find the ICU 28, almost 29% were diabetics, whereas in the ward, COVID ward, only about 9.5, 10% were diabetics. So you can see how adversely diabetes can affect patients with COVID positive cases with diabetes. Next. Now, coming to other Indian studies, out of 106 hospitalized patients published from Rajasthan by Saluja from Kota, 79% had comorbidities like diabetes and hypertension. And a small series of 32 patients, also 50% had diabetes, published by Dr. Agarwal et al. From RML Hospital in Delhi. And another small series from Rajasthan, Jaipur, so about 8% were affected. This is from radiology department, where they have gone for their CT thorax. But if you look at Dr. Bhandari's series, it's a very important series. 80 cases confirmed with COVID-19 were studied, and 56% had diabetes mellitus. They're all RT-PCR positive cases.
Now, in this landscape, when we know that COVID-19 is associated with diabetes, which are the anti-diabetic medicines which can act and reduce the MH, that is a major histocompatibility complex, or at any level they can be interacting? Are there any drugs which can reverse whatever we have shown as a relationship of diabetes with COVID-19?
I think we have to go down. I think this is next one is pro-inflammatory.
Okay. So
Okay, we'll go.
coming
Why
back
there's
to coming back to pro-inflammatory and hypercoagulable state of diabetes mellitus, this disease is an inflammatory, post-viral, it is an inflammatory disease which causes both Th1 and Th2 response. In both Th1 and Th2 response, it makes the blood more hypercoagulable, and it increases pro-inflammation, which is a cellular response. So how that normal viral hypercoagulable stall is linked to diabetic pro-inflammatory and hypercoagulable state?
next slide, please.
Yes, it is there.
No, it doesn't show.
No, this and this.
No, there must be a chapter heading slide, hypercoagulable state.
This is what.
No, this is showing the COVID-19 and diabetic, other Indian studies. I think it's
No,
got stuck up.
several mechanisms explain the relationship.
No, it's not showing in my computer. Manmit, can you help us?
Is it now showing? Is it now showing?
So I'll reshare it again.
Now you see?
Yeah. Yeah, sure. Yeah. So diabetes, all of us know in COVID-19, there's a huge cytokine storm. You know, the pathogen, the COVID virus, once it gets internalized into the pneumonocytes, and especially and it leads to its hyperactive state of a huge immunological challenge to the body, and the cytokine storm sets in. But diabetic situation is different than non-diabetics, because there's a pro-inflammatory and hypercoagulable state per se exists in diabetics. Several mechanisms explain the relationship between chronic inflammation and insulin resistance. Diabetic state per se is a pro-inflammatory state because there is hypersecretion of pro-inflammatory cytokines like IL-6, tumor necrosis factor, TNF, and many other cytokines. And there is a major stimulatory effect on the synthesis of acute phase proteins by the hepatocytes of the liver. So enhanced expression of inflammatory proteins by the counteracting physiologic effect of insulin on hepatic APP, acute phase protein synthesis, as a result of decreased insulin sensitivity. The cytokines would act as a primary stimulator of APP gene expression. So there are several molecular mediators and inflammatory proteins which comprise of acute phase response. And in a diabetic who is not well controlled, it's the patient himself or herself is in a state of severe pro-inflammatory state. Next, please. Now, what happens to adiponectin? Adiponectin is inversely associated with traditional cardiovascular risk, and the adiponectin is reduced in obesity, insulin resistance, and type 2 diabetes. It has many anti-atherogenic and anti-inflammatory and properties, and thus, if there is a low adiponectin levels, which is seen in type 2 diabetics, it per se reflects that is in a pro-inflammatory state. So multiple abnormalities, including platelet function, coagulation, and fibrinolysis have been described in patients who have diabetes. Increased platelet aggregation and increase in fibrinogen factor 7, voluminous factor, PIA has been seen in type 2 diabetics. Next, please. Well, this is one of our studies we published way back in 2012, where you can see we are worked out with the HSCRP, adiponectin, and nuclear factor kappa B, which is a marker of acute inflammation. And you can see the patients, diabetics with macrovascular disease. And then second column is those without macrovascular disease, and third column is healthy controls. You can see the HRCRP was much, much higher in patients with macrovascular disease, and even those without macrovascular disease, diabetics had much higher CRP levels than healthy controls. Adiponectin levels were definitely lower than healthy controls, and nuclear factor kappa B expression was much higher in diabetics compared to healthy controls. If you look at the diabetics in the first column, without macrovascular disease also, these profiles were higher. So the HSCRP values were significantly higher in both groups of type 2 diabetics. Nuclear factor kappa B expression was significantly higher, and adiponectin were lower in diabetics with macrovascular disease. So in a situation of COVID challenge, these things worsen. That's why a diabetic fares much worse than compared to a non-diabetic with COVID infection. Next, please. Well, this is another study where you looked at the interleukin 17 levels in diabetics, which is a pro-inflammatory cytokine. The levels were increased in type 2 diabetics. And in multivariate logistic regression, interleukin 6 has been found to be an independent marker for severity of degree of neuropathy and retinopathy. So that's why microvascular disease is also more in type 2 diabetics, which suggests an inflammatory state of diabetes with or without complications. So per se, diabetic is a pro-inflammatory state. Next, please. Yeah, now, coming to the Chennai Urban study published by Dr. Mohan and his team, they found that the collagen-induced GB, 2B, and 3A binding was significantly higher in diabetics. The collagen-induced GB2, 3 bindings to be significantly associated with coronary artery disease with diabetes. So, if you look at the activation of the endothelial activation and the activation of the platelets and thrombus formation is also much more in type 2 diabetics. And we know COVID-19 leads to hypercoagulability state leading to thrombus formation and leading to both acute coronary syndrome or coronary artery disease and also stroke. Next, please. This is another interesting study from South India by Dr. Ritu Madananal. They can see if you look at microvascular complications, if you look at protein C, PIA1 and volume-enabling factors, and this is diabetics without complications, diabetics with complications, all were much higher compared to p-value in the diabetics with complications than without complications. So you can see that also in microvascular disease, the patients have more of PIA1, more of volume-enabling factor, and more of protein C. Next, please. Now coming to statins and diabetics. Just before going to statins, I just like to revise our knowledge regarding the different cholesterol transport systems. So this is the endogenous. On the right side of the screen is the endogenous lipid transport, which shows that cholesterol is synthesized in the hepatocyte. This cartoon shows hepatocytes. It can be, some cholesterol come back through HDL cholesterol. Some are synthesized de novo by the hepatocytes, and some can be from the de novo from carbohydrate sources, And the apoproteins also are synthesized by the liver APO100. And that is why what happened, they secreted as VLDL, and VLDL loses its triglycerides in the peripheral circulation and gets converted to LDL. So LDL is a byproduct of VLDL, and excess production of cholesterol by the liver can be inhibited. Next, please. Next slide, please. So HMG-CoA or 3-hydroxymethylglutarate coenzyme and reductase inhibitors work by inhibiting the synthesis of cholesterol in the liver by the enzyme HMG-CoA reductase. So they are pharmacologically known as statins because they are pravastatin, fluvastatin, atorvastatin, simvastatin, and rosuvastatin. They are the mainstay of therapy for elevated LDL cholesterol, as I have shown in the previous cartoon. That LDL cholesterol takes place in the liver, and these statins, they suppress the HMG-CoA, the key enzyme for synthesis of cholesterol. Next, please. Now, coming to the ADA guidelines to divide diabetics patients into the 3 groups. That is, ADA guidelines on the use of statins in patients with type 2 diabetes mellitus, younger than 40 years of age, aged between 40 to 75 years, and older than 75 years. So those who are younger, those type 2 diabetics who are younger than 40 years of age, no statin for those with no cardiovascular disease. Risk factors. Moderate intensity or high intensity statins doses to those with additional CVD risk factors. That is LDL cholesterol more than 100, high blood pressure, smoking, overweight, obesity, etc. Then high intensity statin dose to those who have overt coronary cardiovascular disease. So if we have a type 2 diabetic, 40 years of age, no risk factor, standard body weight, good exercise and everything, you need not start with statins. But if these risk factors are present, statins have to be given. Now, 40 to 75 years, moderate intensity statins for those with no additional risk factors. So here, even if they have no risk factors, some statin has to be given to prevent atherosclerosis, because atherosclerosis is an ongoing process. It proceeds with life. And high intensity statins for those who have either CVD risk factor or overt CVD cases. And over than 75 years, moderate intensity statins for those with CVD, high intensity statin for those with overt CVD. Next, please. Now, statins, the ADA indication of statins were recently published in November 2009. You can see statins therapy should be added to overt cardiovascular disease. A level of evidence is A. For low risk patients than those specific above without overt cardiovascular disease under 40 years, the level of evidence is E. And if the drug treated patients do not reach the above targets on maximal tolerated statin therapy, a reduction of LDL cholesterol of more than 40% from baseline attempt alternative therapy has to be added, ezetimibe has to be added, or is evidence A. So combination of therapy using statins has not been evaluated in outcome studies, but you can add combination therapy with fenofibric when the triglycerides is also high. A very important thing is statin therapy is contraindicated in pregnancy. I was to draw your attention of all the viewers, please. May I go to last slide, please? Last slide. Because pregnancy per se induces a state of hypercholesterolemia. It's a physiological state because the body shifts, the mother's metabolism shifts from glucose-centric to lipid-centric because glucose is fed to the fetus, growing fetus. So in those cases, in a pregnant woman, we may get high cholesterol levels and no statin has to be given except only dietary modifications. Next, please.
So as statins can indicate a hypercoagulable state also. Therefore, apart from statins, another two drugs which are important are aspirin and hydroxychloroquine. Aspirin is reducing the COVID-19 situation and hydroxychloroquine is an anti-diabetic drug. Let's listen about that.
The role of aspirin and hydroxychloroquine. Now, aspirin, coming to aspirin in humans, high dose of aspirin treatment resulted in approximately 25% reduction in fasting plasma glucose, associated with an approximately 15% reduction in CRP, that is the pro-inflammatory acute phase reactant or the acute phase protein, and total cholesterol, approximately 50% reduction in triglycerides, and approximately 30% reduction in insulin clearance. So hyperglycemia is taken care of, especially fasting hyperglycemia and postprandial, because if the clearance of insulin, naturally secreted insulin, the beta cells is delayed, naturally the glycemic control becomes better. Recent studies have examined whether, back please, whether non-aspirin inhibitors of, platelet aggregation have added benefit to diabetics. Clopidogrel versus aspirin in patients with risks of ischemic events trial has shown, as a post-hoc analysis shown, that clopidogrel reduces a composite CAD endpoint 12% more than did aspirin, and the effect was greater than observed with non-diabetic subjects. In addition to clopidogrel caused less bleeding. So next slide, please. We'll be discussing more. Not all patients with, because of the potentiality of causing bleeding, not because there's a Canadian study which has shown that the intracerebral hemorrhage was more in the aspirin group, diabetics. Not all patients with diabetes mellitus should be routinely prescribed daily aspirin for prevention, regardless of their cardiovascular disease. Aspirin is routinely prescribed for prevention of cardiovascular events that include non-fatal myocardial infarction, unstable angina, ischemic stroke, transient ischemic attacks, or cardiovascular death. The benefit of aspirin is primary prevention in patients who have a low risk profile. I'd beg to draw your attention of all my viewers with the low risk profile events is questionable. Is the routine practice of aspirin for all diabetic patients has been controversial. So when there is non-fatal myocardial potentiality of developing myocardial infarction, stroke, and a patient with unstable angina, aspirin is prescribed. Nevertheless, administration of daily dose of aspirin of 81 milligram is well recognized in diabetics for secondary prevention. Next, please. Yes. Hydroxychloroquine. It's an anti-diabetic effect of hydroxychloroquine was first described way back in 1984 in a patient with severe insulin resistance in whom addition of hydroxychloroquine dramatically reduced insulin requirements. Interestingly, there is growing evidence of their beneficial impact on cardiovascular risk, particularly in diabetics and dyslipidemia. But the mechanism of action responsible for these effects remain ill-defined. And a retrospective cohort of 1127 patients with rheumatoid arthritis, where regularly hydroxychloroquine is given as a DMRD, disease-modifying agent, 71% reduction in the risk of incidence of diabetes. So the DGCI has approved in 2014 July that hydroxychloroquine has been approved as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes on sulfonylurea and metformin therapy, but it's not strongly recommended. It's a third-line treatment.
So it is a
Next.
time, COVID-19 is a time to reverse diabetes. Once you know that COVID can be lethal with diabetes, it is a time for all of us to either reverse or control diabetes very well. Is there any evidence? Can diabetes be reversed?
And diabetes reverse next. Reversal of diabetes. Although the common denominator of diagnosis of diabetes is chronic hyperglycemia, with regards to etiopathogenesis, there are a variety of causes. We know the classification of diabetes mellitus is a huge basket. It is etiopathogenic in 1996 and 97, 96 ADA and 97 WHO endorsed it. The current classification which you are following is etiopathogenic classification diabetes, where you know a variety of causes can lead to diabetes. So which diabetes are primarily reversible? And diabetes due to secondary causes like drugs, steroids, immunosuppressive medications can be potentially reversed with withdrawal of the inciting cause. And a condition called as a fibrocalculous pancreatic diabetes, when there is a stone formation in the exocrine pancreatic duct, in the exocrine, the main duct of the pancreas. This was first described in many countries, and late Professor E. Varghese from Kerala had lots of contribution about this. And Dr. V. Mohan's PhD thesis was also on FCPD from Madras University. And FCPD can be reversed by surgical intervention before exocrine endocrine pancreas is destroyed. If you remove the stone surgically, diabetes reverses. Impaired glucose tolerance and GDM or gestational diabetes mellitus are potentially reversible conditions through lifestyle modification and medications with either AGI or metformin. Obesity, corpulence, and PCOD are conditions that induce insulin resistance and diabetes. Intervention, these three situations can definitely reverse diabetes. Next, please. Even though all individuals with type 2 diabetes pass through, this is a very important thing, I draw your kind attention, through a pre-diabetic phase, not all individuals with pre-diabetes will become type 2 diabetics. This is a very important thing. If we can catch the bird early, we can intervene. If there's a strong family history, and the person has all the risk factors like obesity, central obesity, and hyperdyslipidemia, hypertension, we can intervene, because approximately 5 to 10% of people per year with pre-diabetes will progress to diabetes, with the same proportion converting back to normal glucose tolerance or NGT. So if we intervene, lifestyle modification and drugs like metformin and carbos, definitely we can reverse diabetes in these patients, in these persons I would put. Now, the Indian Diabetic Prevention Study by Dr. Ramachandran and his group, published in Diabetologia, said that it was a 28 point, almost 30% reduction in conversion of IGT to diabetes with metformin and lifestyle modifications. So this is an Indian study, and we look at the international studies also, obesity and diabetes. Obesity and abdominal obesity are strongly linked to diabetes mellitus. Obesity is considered to be linked with insulin resistance, metabolic syndrome, diabetes, hypertension, dyslipidemia, and coronary artery disease. Evidence from link between reducing obesity and reversing IGT and diabetes comes from epidemiological studies. The DPP program revealed a 7% reduction in weight and lifestyle modification could prevent subjects up to 58%. And the Finnish diabetes prevention study, the Japanese woman prevents diabetes prevention study. Next, please.
Now, coming back to the vaccinations, two things. What are the vaccinations required in diabetes? And number two, will diabetes come as a priority segment to be given COVID-19 vaccine once available?
Yeah, the schedules for vaccination as followed in the Western world for type 2 diabetics and type 1 diabetics. There are 5 vaccines have been recommended for diabetic educators should promote among persons with diabetes or persons with diabetes or PWD to mitigate their risk of serious disease and complications. One is influenza vaccine, which has to be given every year, or the flu vaccine. The tetanus, diphtheria, and pertussis vaccine. This vaccine in India is a part of the routine immunization schedule in children. So, however, those who haven't had that dose of tetanus, diphtheria, and pertussis have to take it. Now, zoster vaccine in the United States, almost 1 in 3 people with US will develop shingles or zoster. So they are more worried about it. It's not a problem with us. We don't have such high proportion of patients, the persons developing herpes zoster virus disease. So CDC recommends all persons aged 50 years to have zoster vaccine. Pneumococcal vaccine Persons with diabetes are increased risk for pneumonia, bacteremia, and meningitis. So 1 dose of pneumococcal vaccine before the age of 65 and 2 more doses after is recommended for pneumococcal vaccine. Hepatitis B vaccine is now included in the primary immunization schedule of all newborn children. So for India, it is a routine immunization schedule which is given for global immunization. So it's not a challenge, but in case of those who have not taken hepatitis type 2 diabetics, hepatitis B, because if you know diabetes leads to more of non-alcoholic steatohepatitis, and if there's another burden of hepatitis B, naturally it will progress to liver cell failure, cirrhosis and liver cell failure, and may be liver cancer. So in those patients, definitely hepatitis B has to be given. Next, please. But the recommendation which is published in JAPI, which is accepted by all of us, in Indian scenario, all adult diabetic subjects will be educated about administering pneumococcal and influenza vaccine. These two vaccines are very important for our diabetics, and those above the age of 60 years should be strongly advised to be vaccinated. So this is very important in Indian scenario. And regarding children, and more so today is Bal Divas, Children's Day, children with diabetes, type 1 diabetes, of more than 2 years of age can be given pneumococcal polysaccharide vaccine, and children above 6 months of age influenza vaccine. So influenza vaccine is not given to neonates. The pneumococcal vaccine is not given to neonates. It's given up to once they're a little elder, about more than 2 years. Other vaccines may be administered in diabetic subjects based on need, as I have already discussed. Patients with the cautions are patients with in type 2 diabetics and type 1 diabetics who are elderly. Renal failure in any age group can be immunized. There's no hassles for immunizing patients with CKD. People with diabetes and immunocompromised state due to concomitant conditions can be immunized irrespective of their age. Patients with diabetes and chronic lung disease like chronic obstructive airway disease, bronchial asthma may be immunized irrespective of the age. And people at any age of diabetes who smoke has to be immunized. And regarding the question asked by Dr. Agarwal, a very pertinent question regarding once the COVID-19 vaccine is available in India, should the priority become diabetics? No doubt about it. Looking at the scenario that how diabetics are much more adversely affected than non-diabetics with regards to morbidity and mortality due to COVID-19. And they're already more prone to develop this infection. And those diabetics who have already respiratory infection are more prone to develop COVID-19. COVID vaccine should be given in priority to patients with diabetes mellitus.
So thank you, Dr. Raj, for
Thank you so much.
very important and lucid answers. I'll take a few questions. Now, suppose
sure.
I have a patient who has COVID-19 and he has COVID-19 pneumonia. So I'll go back to the standard treatment and then say what need to be added in a diabetic COVID-19. We give a anti-inflammatory, we give a antibiotic which has an antiviral effect, doxycycline or azithromycin. Both of them have enough data to say that they have antiviral effect. Any preference in diabetic?
Well, first of all, if diabetic is on oral anti-diabetic drugs, it has to stop the insulin. That's very important.
No,
glycemic control. If we're talking about diabetic.
No. I'm starting with one by one. I'm starting patients of all patients with COVID-19 are receiving either they are receiving doxycycline or azithromycin. Is there a preference between the two when it comes to diabetes, or anyone will do?
Preference with the diabetic, anyone will. Azithromycin will prefer to doxycycline.
Okay. Number two comes is ivermectin now is being given by many states, including UP state and many other states are giving ivermectin. Is there any role, is there any preference among diabetics, or we carry on the way physicians feel their professional independence?
Well, the evidence is a very low standard to recommend ivermectin in a COVID positive patient.
So the third thing,
if the state governments having their own healthcare programs, I would not object to that. But as a senior physician, I would strictly not recommend ivermectin.
The third thing
is not proved.
The third thing is hydroxychloroquine. All diabetics, because hydroxychloroquine also has anti-inflammatory, antiviral effect. Do you recommend all diabetics?
Well, we discussed about hydroxychloroquine, and especially because it helps in mitigating the cytochrome cytokine storm. So we know that COVID induces cytokine storm. So from that point of view, when patients were already infected with COVID, hydroxychloroquine definitely is recommended, or it's already recommended by different schedules already published in India. And the purpose is to douse the cytokine storm.
So hydroxychloroquine. Next thing which comes is statins. We have seen in COVID-19 hypercoagulable state. Do you feel that among diabetics we should strictly follow and bring LDL to less than 70 to prevent macrovascular conditions? We should aim in COVID-19. If they are not on statin, we add them, and if they are on statin, we go to high dose statins so that we can bring statins LDL to less than 70.
Well, the algorithm I've already discussed 40 years, 40 to 75 and 75 years. But one thing, very pertinent question which you asked, Dr. Agarwal, in patients with COVID infection, statins, especially atorvastatin and rosuvastatin, have been proved to have pleiotropic effect. Besides lowering the cholesterol level, they also have a membrane stabilizing effect, which is very important, which is anti-atherogenic. So definitely in patients who are COVID positive, institution of treatment with statins is definitely most welcome.
So in all patients of hypercoagulable stage, we have seen that patients after developing COVID-19 still develop aspirin may not be able to prevent. So aspirin for prevention and a post-COVID phase. And during COVID phase, if I have to give either a enoxaparin or dabigatran group of drugs, do I continue aspirin in them, or I give it after the enoxaparin or dabigatran is over?
After the course of enoxaparin dabigatran is over, post-COVID, you can give aspirin with clopidogrel if they had developed hypercoagulable state. I think only aspirin is not good, because 40 to 30% of type 2 diabetics are aspirin resistant. And so a combination of clopidogrel aspirin definitely is welcome.
So most of the patients of COVID-19, if they develop excessive tumor necrosis factor alpha, gamma interferon activity, they will develop cytokine release in terms of CRP more than 10, and we need to substitute steroids in them. And we know steroids COVID-19 will worsen postprandial diabetes. How do I handle them?
Well, steroid therapy is a must when there is a cytokine storm, and definitely steroid has to be given as a life-saving, whether you give hydrocortisone to start with and switch over to dexamethasone. And in that situation, there is a hyperglycemia. And definitely low dose of, if his patient is not a type 2, not a diabetic, having stress hyperglycemia or acute hyperglycemia because of COVID infection and the cytokine stress, you have to give him low dose insulin and monitor. And the blood sugar fasting should not go below 110. It should be between 110 and 140, ideally 160. For postprandial and fasting, it has to be glucose has to be monitored, and low dose insulin has to be given.
When we come back to the diabetic pathway, which you have shown, that it increases IL-6, IL-1 beta, IL-18 through nucleofactor kappa B cell pathway, and which ultimately ends up with NLRP, which is node-like receptor P3 pathway. Both these pathways ultimately leads to IL-1B, which is pyrogen, causing fever more than 100, and IL-18, which is causing tissue necrosis. And at both the levels, as on today, I have two drugs which reduces, that is NF kappa beta pathway, and they are colchicine and mefenamic acid. Both these drugs reduces IL-1 beta, IL-118. They reduces the pathway of NF kappa B cells. And do you think that colchicine and meftal, because colchicine now has been standard treatment for acute coronary syndrome, post-MI, and in a stable coronary artery disease, do you feel that mefenamic acid, because of its anti-NLRP effect, and colchicine also, both of them working at the level of this pathway, can also be used as a steroid-sparing drug after 9 days? When you want to continue anti-inflammatory, that means on 9th day, if the CRP is less than 10, but it hasn't become a normal, We need some to prevent post-COVID phenomena. We need a drug, anti-inflammatory drug, like we give it in ankylosing spondylitis, like we give it in rheumatoid arthritis. Before we start DMRD, we give them a 3-month treatment of anti-inflammatory drugs to see whether it responds or not. Do you think we have a game for colchicine and mefenamic acid in diabetes?
Mefenamic acid definitely, mefenamic acid can be used. But regarding colchicine, well, I can't give any opinion.
Okay, so coming back to colchicine is one. Then coming back to fever in diabetics, there are two types of fever in diabetics. One is because of increased permeability of IL-6 into hypothalamus, leading to thermoregulatory dysfunction. And that fever lasts for 3 to 6 months. It is a low-grade fever, comes in the afternoon, goes back in the evening, and CRP may remain normal. The second type of a fever is when the CRP is more than 10, which is a cytokine fever. And in that particular cytokine fever, again, the only drug which is responding is mefenamic acid, much better than other drugs. Do you feel that mefenamic acid also there plays a role?
Well, mefenamic is definitely can play a role, but regarding the fever for 6 months, well, there we have to take care of other causes of fever. We can't just think that is with the interleukin 6 to 1C is definitely produced in a variety of conditions. So a slow fever in diabetic, we have to rule out tuberculosis, we have to rule out other chronic conditions, and especially whether glycemic control is good or not, because we have already discussed that is a situation with pro-inflammatory state. So those things have to be taken care of. And we just can't give a drug which will just take care of the fever and forget about the whole system. So that is not advisable. So,
coming back to BCG vaccination, because nowadays recombinant BCG vaccine is coming. Do you think that giving it to elderly diabetics makes a game for it?
there's no evidence. There's no evidence.
No evidence. What about herpes zoster vaccine? Because we are seeing a lot of cases of this COVID-19 precipitating herpes zoster.
Yes,
so do you think
that can be given. That can be given. Chickenpox vaccine can be given.
So
It's
shingles
already
vaccine,
recommended by the
I
CDC.
know. They are recommended, but I am only trying to find out a point in India, the Indian vaccination program, because we are the diabetic capital. So we should tell the people, those who can afford, they should take a shingles vaccine.
Sure.
And those who can afford should go to pneumococcal vaccine. In pneumococcal, we have two choices, pneumococcal 13 and 23. Are we advising both or only 23?
23.
23. So in elderly, we go for pneumococcal 23 vaccine. Flu quadri once in a year you can give. And if you have short of money, you can't afford flu vaccine, you can go to a off-label intradermal use of flu vaccine, which you can share within your family to reduce the cost. We had discussed yesterday about COVID-19 with Dr. Ganguly and Dr. N.K. Arora in the last 2 days in our shows. And there also a time will come if there is a vaccine shortage, you may start thinking of intradermal approach to give immunity, though that there is no scientific evidence as on today, but the evidence needs to come in that particular thing. My last question is that once we know that diabetes, if you control the diabetes, you are controlling, my definition of controlling the diabetes is to bring your CRP to less than 1. That's what I say, a controlled diabetes. I am not bothered about HbA1c. I always say if your diabetes has no pro-inflammatory state, and if your CRP is normal, indirectly your fibrinogen is normal, and indirectly your IL-6 is normal. If all diabetes can bring your IL for CRP to less than 1, that's the time for us to create awareness. The diabetic is a pro-inflammatory condition. COVID-19 is a pro-inflammatory condition. If we really do this,
I have an idea here that HbA1c and HRCRP, they're interlinked. If the HbA1c is higher, that means the glycemic status is very poor, and naturally the CRP levels will be higher. The markers of inflammation will be higher. So they are interlinked. You cannot separate both. You are talking from the view of a cardiologist. I do appreciate that. But here, both have to be taken into consideration. Just like blood sugar, blood pressure, and lipids. It's not only blood sugar.
I'm only trying to say if your HSCRP is normal, your HbA1c will always be normal. That's the corollary I'm giving. So I'm saying is If you control hepatitis B, HIV is controlled. If you control pollution, PM1, then your COVID-19 is automatically controlled. Similarly, if you control inflammation in diabetes, inflammation will never be controlled unless your HbA1c is controlled. So but reverse is not true. You may have a tolerable HbA1c, but high hsCRP. So if you really want to be good in your life, so I am now promoting a lot of CRP, small, simple, easily available, less costly, and the marker for COVID-19. And I'm sure this is the marker for low-grade inflammation, whether it is NAFLD, whether it is non-steatic alcohol-hepatitis, whether it is fatty liver, PCOD, whether it is diabetes, whether it is pot belly obesity. So somehow or the other, if we work on a CRP reduction, and if you see this, all Ayurvedic now have taken a lead. The complete Ayush department has taken a lead. They're only controlling CRP. They're only talking about cytokines. And if they end up in formulating some herbs which reduces CRP, we will be lacking behind in our modern medicine in finding drugs which work at the level of interleukins, which work at the level of tumor necrosis factors. At this moment, we have very, very few drugs which reduces inflammation except steroids. Now, I've seen a study where it says the herbal Calmake reduces PLA2 much higher than steroids. PLA2 is the phospholipid A, which causes the arachidonic acid and leukotrienes pathway. And the study shows that Calmake as a plant has products which are much stronger than steroids. So I'm only trying to say is that if we start working on CRP reduction, maybe from India we may find a lots of answer. So it was nice interacting with you, Dr. Das, and I'm always your follower. I'm always your admirer for long.
Thank you so much. Thank you so much.
And
I'm honored. I'm honored, sir, because you called me for even if it's Diwali evening. I said no. I should take advantage of the three things I told you today. This is Diwali. It is Frederick Banting's birthday, and it is Bal Divas.
So thank you everybody for being here. I'm thankful to all the people who still on Diwali day you have been able to attend this. And that's all for today. Tomorrow 7 p.m. we will be back with another show of Med Talks with Dr. K.K. Agarwal. Keep watching. Stay tuned. Namaskar.